Hello everyone, welcome back. Moving on towards the last part of the surveying, that is the uses of the surveyor, that is the part 3 of surveying. So these are the uses of surveyor. These are the 11 uses. The first is surveying the diagnostic and primary cast. Second is tripoding the cast, tri- transferring the tripod marks to another cast, contouring the wax pattern, contouring the crown and the cast restoration, placing internal attachments, placing internal rest, serving the master cast, serving ceramic veneers, and blockouts of the mastercast, and there are some other uses. So basically this all are the 11 uses of Surveyor, and I'm going to explain all of these in details like one by one. And in my last video I have talked about setup for surveying. So in setup of surveying we have seen, first we mount the cast, then we position the surveying arm. The third thing that we do is analyzing the cast. So analyzing the cast is nothing but we are tilting it appropriately. And after that, what we do is we survey the diagnostic or primary cast. So this is the fourth step which we do in surveying. So surveying the diagnostic and primary cast. The diagnostic cast, it should be surveyed before the treatment planning, whereas the primary cast, it is surveyed after the completion of the pre-prosthetic mouth preparation. So diagnostic, as the name says, you're using this cast for the diagnosis and you're doing this before treatment planning. And primary is when you have done all the, if the patient requires any surgical treatment to be done. So at that time, pre-prosthetic mouth preparation to be done. So after that, the cast that is prepared is your primary cast. So the primary cast, it is surveyed to determine the required amount of prosthetic mouth preparation, design and mark the outline of the prosthesis. And for example, if the patient did not require any prosthetic surgeries to be done, so your diagnostic cast, it acts as a primary cast. So what are the objectives of surveying the primary cast? To determine the most accepted path of insertion. So as we have seen, the main objective of surveying is to determine proper path of insertion or proper path of placement. So path of placement is nothing but how you're placing and removing the denture. So to determine that, then the next is to determine the proximal tooth surface on which guiding planes can be prepared. So these are the guiding planes. To identify that guiding planes, to locate and measure the retentive areas in a tooth. So now your denture, it requires that retention. So to locate and measure that area, we are doing this survey. Then the next is to determine the soft tissue and or bony interference which are to be eliminated. So the next is you're determining the soft tissue or a bony interference which we do not require to be fabricated in a denture. The next is to identify the height of contour. Height of contour, as we have seen, it is the bulkiness of the tooth. So to identify that, then the next is to identify the undesirable undercuts that should be blocked out during casting. Undesirable undercuts are those like soft tissue undercuts or any bony undercuts. So those are the undesirable undercuts and it should be blocked out. Because if you fabricate your denture into this undesirable undercuts, then there are the chances that your denture will break off. Then the next is to record the cast position for the future reference and to plan and determine the required mouth preparation procedures like preparing the guiding plane, rest seats, etc. So these are the objectives why you are surveying the primary cast. Now it includes these three steps. So first is analyzing the cast, surveying the teeth, and surveying the soft tissue contours. Analyzing the cast we have seen in our last video for the setup of surveying. In that I have explained what this analyzing the cast is. So after that what we do is we survey the teeth. Now surveying the teeth, why are they surveyed? So they are surveyed for this 5 reasons: to determine the height of contour, to determine the depth of the undercut, to determine the location of the undesirable undercuts, and to determine the parallelism of the abutments, and to determine the path of insertion. So the first one, to determine the height of contour. So teeth, they are surveyed to determine the height of contour. Now depending upon this, depending upon the height of contour, the clasp of the RPD it is designed. So clasp is like we have seen, like I have covered this video on direct retainers. So direct retainers are nothing but your clasp. So the clasp it is designed depending upon this height of contour. The rigid component of the clasp, it should be above the height of contour. So for example, your height of contour is over here. So as we have seen in direct retainers in that video, I have talked about they have a rigid components and flexible components. So your rigid components, it should be above this height of contour, and the flexible component, it should be below this height of contour, and it will engage that undercut. And the only flexible component of direct retainer is the retentive terminal, that is your retentive tip. Rest all are the rigid components which are above the height of contour. So the rigid components of the clasp, it should lie above the height of contour, and the flexible parts of the clasp, it should be placed below the height of contour. Hence we understand that according to the height of contour, the design of the clasp will vary. So depending upon this height of contour, you will see which clasp do you need. Then the types of clasp and everything I've explained in that video of direct retainers. The height of contour, it is marked with a flat surface of the carbon marker. So this is your carbon marker, and you're marking the height of contour with it. This forms the survey line. So your survey line, it forms the survey line. If there is no height of contour and there is no undercut to place the flexible, for example, there are some teeth, they don't have this height of contour, they are approximately flat and they don't even have undercuts. So at that time, what you do is you create this. So this is the procedure which is known as dimpling. So dimpling, it is like you create a small depression to engage the flexible part. So you're creating this depression so that the flexible part of your direct retainer, it goes and engages this part. Or there can be alternative to this is you recontour the tooth with a crown. So you're placing a crown. So these are like the examples. The teeth which have no undercuts, you are doing this dimpling, and the alternative to this can be placing a crown. So this is determining the height of contour. Then determining the depth of undercut. This is done using a undercut gauge. So you're using this undercut gauge, and one should remember that the depth of undercut is not always measured at the level of gingival crevice. So you should remember that whenever you are measuring the undercut, so with the help of a undercut gauge, so you're not always determining it at the gingival crevice. Instead, it is measured at the level where the operator he plans to place the retentive terminal. Then a more flexible material should be used to engage a deeper undercut. If there is a deep undercut, so more flexible component is used, and depending upon that, you change the alloy which exactly you are going to use. So there are different alloys with which you make the direct retainers. Depending upon that, now you're going to change the alloy. Then the next one, so this is the determining the depth of the undercut. Next is determining the location of the undesirable undercuts. So now we have seen undesirable undercuts are those which are like soft tissue undercuts or bony undercuts. So undesirable undercuts, it should be blocked out or it is filled. So this is the undercut over here. This was an undercut, and this is blocked out with a wax. Now usually this blocking out is done on a master cast, and before duplicating it to a refractory cast. So this is like blocking out of the undercut. Then undesirable undercut, it should be filled or it should be blocked out till the height of contour. So when you are filling it or when you are blocking it, so you are using this wax till the height of contour. Now over here, as you can see, you're using this till the height of contour, and whatever the excess is, then you are trimming it with a trimmer. Then you're like trimming it with a trimmer. So this was the third one, that is determining the location of undesirable undercut. So basically you're just blocking it out. The next one is determining the parallelism of the abutment teeth. So this is like the parallelism of abutment teeth to one another, it should be determined. The path of insertion of the RPD is usually parallel to the long axis of the abutment teeth. So the path of insertion, so this is the path of insertion. So basically it is parallel to the long axis of the abutment teeth. The path of insertion. The parallelism is essential for easy insertion and removal of the prosthesis. If it is absent, it should be established by contouring the enamel surface or by placing the restoration on one or more teeth. The undesirable undercuts in the teeth should be identified and eliminated. Now, for example, now if your abutments, they are tilted, so your path of insertion, it will change. So basically, we are just determining the parallelism of the abutment. If the teeth, they are in a proper position. So your path of insertion is same as that of your abutment. And if it is not parallel, if your abutments they are not parallel, then you are changing it properly, appropriately, so that you have a good path of insertion. The next is determining the path of insertion. So this is like the most important, as we know, determining the path of insertion. While surveying to check for the parallelism of the abutment teeth, the cast it is tilted till the long axis of the abutment teeth is parallel to the vertical axis. Now over here, for example, now this is a tilted tooth, tilted abutment. So because of this, the path of insertion will also change. So basically, what you're doing is you are serving in such a manner that the parallelism of the abutment teeth and the cast it should be tilted such that it is parallel to it. So if it is not parallel, so you're tilting the cast so that it becomes parallel to it. For example, now your parallel will be like this, or slant. So you are tilting your cast in such a manner that it becomes parallel to your abutment. The tilting it can be done in anterior, posterior, right or left direction, as we have seen for the analyzing of the cast in the last video. And the established tilt it should not exceed 10 degrees. Now remember this, it is not exceeded beyond 10 degrees. If the established tilt it exceeds 10 degrees, the designed RPD it would require excessive mouth opening for insertion, which is not appropriate. So this was the determining the path of insertion. So these are the 5 reasons why you actually are doing, why you are serving the teeth. The last one is serving the soft tissue contour. So first one was analyzing the cast, second was one serving the teeth, and third is serving the soft tissue contours. So soft tissues to be covered by the prosthesis, or the soft tissue that supports the prosthesis should be surveyed for undesirables undercuts. Over you. If any form of surgery is needed to eliminate these undercuts, they are added to the treatment plan. Remember, serving the diagnostic cast, it comes under the diagnostic phase of RPD treatment. So this is like you're scribbing the cast at the height of contour of a soft tissue undercut. So this was like now undercut. This is undercut gauge. Undercut gauge it scribs a mark, and then you are marking it with a pencil to highlight it properly where the undercuts are. So this was the first use of it, that was serving the primary or diagnostic cast. The next use is tripoding the cast. Now the angle of path of insertion it is maintained by maintaining the tilt determined from the primary cast. To achieve this degree of tilt for the master cast, tripoding the primary cast is done. So now what you have done, you have tilted your cast. So this is the next step that you do. So you have tilted the cast, you have analyzed it properly, you have surveyed the primary cast. Now you're doing this tripoding of it. Tripoding is nothing but three. Tripod is three points. So now you have determined the path of insertion by tilting the cast. So the next thing you do is you mark some points on the cast, so that now you have tilted the cast. So how you'll know that you have tilted the cast, if you're after that you survey the master cast. So how you'll know at what degrees and how much you have tilted the cast. So for that you're doing this tripoding the cast. To achieve this degree or of tilt for the master cast, to achieve this degree of tilt for the master cast when we are serving the master cast, so this tripoding the primary cast is done. If the path of insertion is not used for the master cast, all the prosthetic mouth preparation proceed will become useless. So if you are not using this path of insertion which you have done, so after that what you have done is you have surveyed the primary cast. Then you have, if the patient he required any prosthetic mouth preparation, then you have done that. And if you haven't done this tripoding, then the path of insertion, how you'll know what the path of insertion was? So the procedure it becomes useless, and hence it is very important to preserve the tilt of the primary cast. So at what degrees you have tilted the cast, you should preserve that. Then recording this orientation of the cast, it is done by the procedure called tripoding. The tripod points, they are the reference point, and it should not be altered till the end of the treatment. So you mark the points on the cast, and so 3 points you are marking on the cast, and they're used as a reference point. So what is the use of a tripoding the cast? So it is positioning the master cast and remounting the diagnostic cast if required. So basically it is like you are transferring whatever the tilt was on a master cast with the help of this tripoding the cast. Now what is the procedure? Tripoding is done after serving the primary cast. With the primary cast, after that you are tripoding it. Then the primary cast, it is mounted according to the determined tilt on the serving table. So you are tripoding, so the primary cast, it is mounted according to the determined tilt of the serving table. Then a carbon marker, it is trimmed at an angle of 45 degree. It is fixed to the mandrel. A carbon marker is fixed on it. The carbon marker is fixed on the serving arm. Then the height of the horizontal arm is adjusted such that the carbon marker, it touches the tissue lingual to the teeth. So you're adjusting the horizontal arm such that the carbon marker, it should touch the lingual part of the teeth. Then the horizontal arm, it is locked in that position. After that you are locking this arm. Then the serving arm, it is moved freely. Since the horizontal arm is locked to the vertical arm, the tip of the carbon marker will lie in the same single plane. So now you have blocked your horizontal arm. And then you can move this serving arm freely in the same plane as you have locked the horizontal arm. Then, as the serving arm is moved, two additional points in the cast that come in the contact with the carbon markers are marked. So you're moving it. So you're freely moving the serving arm, and two more points you're marking whenever this carbon marker, it touches the cast, wherever it touches the cast. So it's like all these 3 points, they are marked using it, will also lie in the same plane. Since the carbon marker is in the same horizontal position, now we have locked the horizontal arm. So it's like this all three marks, they are coming in the same plane. One technical consideration is to be remembered that the side and not the tip of the carbon marker, it should be used to mark the tripoding points. This is because the side of it is used and not the tip of it. The side of the carbon marker is used and not the tip. Now over here, as you can see, the side, it is like tripoding it and not the tip of the carbon marker. Because what happens that it is because if the tip is used, it can abrade and it can provide a faulty reading. So if the tip is used, it can abrade this cast. So because of that, you're using the side of it. Now, as an alternative to tripoding, the orientation of the cast can also be recorded by scribbling a vertical line on the cast. So over here, instead of tripoding, the model can be also be indexed by drilling and cementing an old burr shank. So over here, so instead of tripoding this, what you can do is you can drill this burr shanks on it. This is an alternative which is not usually done. So what we are doing is tripoding is nothing but we are marking these 3 points on the primary cast with that procedure that I have explained, so that you can now transfer this point on the master cast for the proper fabrication of RPD. Then the next is transferring the tripod marks. It is done to orient the master cast using the same angulation. Now we have seen we have marked 3 points, but with that additional 3 reference points are marked after tripoding. So additionally you are marking these 3 points. So remember this, it can come as an MCQ also, like they'll give you 4 options and they'll tell you which one is the wrong one. So which is not the additional reference point. So you should know this well. So the first additional is the distal marginal ridge of the first premolar over here. So it is the distal part of the first premolar. Then the next is the incisal edge of the lateral incisor. So it is the incisal edge of the lateral incisor. And the last one is the lingual cusp tip of the first premolar on the opposite side. So now, for example, if you have marked this distal marginal ridge on suppose 1-4, so the lingual cusp of the first premolar, it should be on 2-4 on the opposite side of this distal marginal ridge point. So this is like you transfer, so you additionally mark this 3 points more on the primary cast and then you transfer it on the another cast. So after marking the reference point, the primary cast is removed and the master cast is placed on the serving table. Since the additional points are located on anatomical landmarks, it is easy to locate them on the master cast. So this is basically we are doing because these are the anatomical landmarks, so it becomes easier for you. So what we have done is we have marked the reference point, then the primary cast is removed and the master cast is placed on the serving table. and we are marking these additional marks. Then the master card, it is adjusted in the serving table such that the carbon marker in the serving arm, it should contact the additional reference point as in the same manner as it was did for the primary cast. So this, the master cast, it should be repositioned and it should be adjusted such that the areas where the tripod points are placed on the primary cast, it should lie in the same plane, and the serving arm can be used as a guide to position the master cast. So we have transferred this on the master cast with the help of some additional reference point, because this reference point, they are the anatomical landmark. So it becomes easier for you when you're transferring it. Then the next is what you do is you survey the master cast. So the master cast, it is fabricated after prosthetic mouth preparation. Now if the patient he requires some prosthetic mouth preparation, so after that you survey the master cast. Then in it is surveyed to check whether the desired result are obtained in the mouth preparation. If the patient he required any prosthetics mouth preparation, so basically you're surveying this master card to check whether the results are obtained. Then all the objective for the serving diagnostic cast, it holds good here too. So what we have seen, all the objectives, so it is same for this serving master cast also, like all the things determining the undercuts, the depth of the undercuts, path of insertion, and all that objectives. But over here, these are the additional following factors that are checked during the survey of the master cast. So what you are doing is you check additional these points when you are serving the master cast. So parallelism of the guiding plane. So first thing that you see is parallelism of guiding plane. So it is measured using the paralleling tools like Surveyor blade, or it is checked by tilting the cast laterally and anterior posteriorly. So this is like you are seeing the parallelism of the guiding plane, and it is used with the help of paralleling instruments. So the diagram for this is this. So this is like the all guiding planes, it should be parallel to one another, and this is checked using a surveyor. So these are the guiding planes, are nothing but the proximal points on the tooth. So these are your guiding planes. So it should be parallel to each other. The next is depth of the undercut and retention. So it is measured using the undercut gauges which is mounted onto the serving arm. So this one, measuring the depth of the undercut to a particular path of insertion using an undercut gauge. So this is the depth of undercut and retention. Then the next is height of contour. Then you're determining the height of contour. It is the widest circumference and is marked using a carbon marker, this height of contour. So it forms this survey line. And the last is the interference. Interference to insertion and removal for the particular path of insertion is checked with the help of a analyzing rod. So interferences are, it can be like the undercuts. So interference can be many. If there are presence of tori or something, so it can act as an interference. So that interference, it is checked with the help of a analyzing rod. So over here, as you can see, these are the proximal points. This was the guiding plane, proximal points. And the guide plane is prepared on the proximal surface of the abutment teeth. On the proximal surface of the abutment teeth, it guides the denture during the insertion only along the path of insertion. They prevent the placement of the denture along any other direction. So this is like basically the objectives of the serving. Then the next thing that you're doing is working out of the master cast. Now you have seen there are undercuts which are present. So then you do this blocking out of the master cast. The survey, it should be used to shape and form the blockouts. So there can be three types of blockouts, that is the parallel blockouts, shaped blockouts, or arbitrary blockout. So parallel is the one, the sites for this parallel blockout can be proximal tooth surface, beneath the minor connectors, and the soft tissue undercuts. What is the purpose of doing this parallel blockouts? It is to facilitate the removal of the prosthesis along the path of insertion. So it helps to remove the prosthesis along the path of insertion if you're doing this parallel blockouts. So it helps in the removal of the prosthesis. Then the shape blockout, the sites are the buccal and the lingual surface of the teeth. The purpose is to facilitate placement of the RPD. So the parallel ones, they are used for the to facilitate the removal of the prosthesis, and the shaped one, is to facilitate the placement of it. And the arbitrary blockouts, they are given at gingival crevices, gross undercuts, then buccal and labial undercuts, which are not involved in the denture design. Removal of the gross tissue undercuts. So if there are any gross tissue undercuts, to remove that, you're using this arbitrary blockouts. So you're giving the shape blockout to facilitate the placement, and parallel blockouts to facilitate the removal of it. So the parallel blockout, the wax is filled in the undercuts and and carved parallel to the path of insertion, and the wax is it's filled in another undercut and it is not carved. So over here, as you can see, so over here you're filling it and you're carving it at one side, and the other side you're filling it and you're not carving it. It is usually used to fill the soft tissue undercut. So basically you're using it to fill the soft tissue. Then the next is the arbitrary blockout. So arbitrary blockout, the wax, it is filled in the undercut area and it is not carved. It is used commonly to fill the soft tissue and bony undercuts over here. And the last one is this formed blockout. This is the formed blockout. The second, this one was the arbitrary. You are filling the undercuts, gross undercuts you're filling. Over here, the first one which we have seen, this was the parallel one. So over here, so it is used to facilitate the removal of the prosthesis. So this is the blocking out of the cast. So these are the steps which are done in the surveying when you are fabricating a RPD. Uses can be, it is help to contour the wax pattern. Now a sharp instrument, it is attached to the mandrel and it can be used to contour the wax pattern. If the cast restoration is to be prepared for an abutment tooth, the wax pattern of the cast should be mounted on the surveyor to check and modify it to obtain an ideal contour. So a sharp instrument, now contouring the wax pattern, you have like used wax pattern over here. This is a wax pattern. So a sharp instrument is used to contour this wax pattern. These are like some more uses of surveyor where it can be used. So if the cast restoration is to be prepared for an abutment tooth, for example, if your abutment tooth needs a cast restoration preparation, at that time the wax pattern on the cast, it should be mounted on the surveyor to check and modify it to obtain an ideal contour. Serving wax knife is used to contour the wax pattern. So at that time you're using this serving wax knife to contour it. Then the guiding plane of the wax pattern, they are prepared until they are parallel to the path of insertion. Basically you are just contouring the wax pattern properly so that it is parallel to the path of insertion. So this is additional use of surveyor. The next is contouring the crown and cast restoration. It can be trimmed using the rotary instrument attached to the surveyor. Then if you have like the contouring the proximal surface of cast restoration, so it's like you required a cast restoration to be prepared on the abutment tooth or the crown. So we can trim it with the help of a rotary instrument which are attached to the surveyor. Then the handpiece holder, it is attached to the serving arm. To this handpiece, with a cylindrical stone is attached to it, and then it is switched on and moved slowly over the side of the restoration to trim the excess crown material. Now you have prepared a crown on the abutment. So to like trim it, you're using a surveyor. Then care should be taken that the favorable undercuts should be created or preserved. So this is like additional use of it. You're contouring the crown and the cast restoration if it is prepared on the abutment. The next is placing internal attachment. So it is similar to hook and loop. Now we know that in direct retainer, as I've said, there are intracoronal and extracoronal attachments. So extracoronal are nothing but the direct retainers, and internal, that is intracoronal, are the attachments that are your internal attachments, and they are like hook and loop. So the loop like structure is placed within the crown and the hook is attached to the prosthesis. So this loop structure, it is placed within the crown, and so this is the adjacent tooth. So the loop, it is placed within the crown and the hook, it is attached to the prosthesis. So it is attached to the prosthesis. Now during insertion, the hook gets locked into the loop to provide retention. It's like lock and key. So these are like they get locked, this loop and hook, they get locked and they provide retention. The basic principle it work on is friction. So this is working on the principle of friction, like it is locking it, and the friction resistance is produced by the component of the retainers. So the procedure for it is like a path of insertion with least interference is determined. Then the attachment, it is like prepared with the where it is cut on a stone teeth of the cast. Then the extent of the recess is determined using radiological investigation. Now basically this is like you're preparing internal attachment to give more retention. If the abutments they are not good, like they do not provide more like proper retention, so we are using this internal attachments, and this can be prepared with the help of this surveyor. So basically it's like additional use of it, and the abutments they are positioned in reference to this with the help of a surveyor. Now the all the attachment that belongs to a single prosthesis should be parallel to one another. So you're just determining the path of insertion. So this is like I have explained, like I've attached a small picture of like what are the advantages or disadvantages of clasp and retention. So over here it is like this attachment it gives 99% retention, whereas clasp there is 30% loss of retention because of all the components, and what you're preparing is clasp are like they're less expensive, they're more expensive, their attachments are more expensive. So this is like the additional use of it. Then the next is placing internal rest. So internal rest, they are large box shaped metallic extension that function as intracoronal retainer. So internal rest is also like the function as intracoronal retainers. They provide more retention. They differ from internal attachment in that they are not prefabricated. And the rest seats, they are formed by sound tooth structure function as a keyway. So this is the internal rest seat. The only difference is they are not prefabricated. Then the next is serving the ceramic veneers. When a RPD abutment is to be restored with a ceramic crown, the contour of the facial surface of the crown is developed in a surveyor. So it is like serving the ceramic veneers. If the abutment tooth, it requires a ceramic crown. So the contour of it, it is developed in a surveyor. The ceramic restoration, it is placed on the cast and the height of contour is verified. So you're just placing the crown on it, and you're just determining properly whether the crown is prepared properly or not. So you're determining, so you're verifying the height of contour basically. And other uses are analyzing the abutment teeth before construction of the fixed prosthesis. It can also be used in the fixed prosthesis. Then to determine the need for alveoloplasty. If the edentulous area it requires alveoloplasty, it is determined with the help of a surveyor. Then to determine the parallelism in aligning teeth that are to be splinted together. So these are like additional uses of surveyor. So these all are the surveyor uses. So with the help of that I have explained the procedure too. So basically what we do in surveying is first we mount the cast, then we position the surveying arm. After that we analyze the cast. After analyzing the cast, we are surveying the primary cast that we have seen in this video itself. After that, what we are doing is we are tripoding the cast. Then we transfer it on the another cast. Then we survey the master cast, and then lastly we are blocking out the cast. This is the general procedure that you are doing for surveying. And the other ones that I've explained are the additional uses. If like not all abutments they require cast restoration or crowns and like that. So these are like additional uses of them. So this was in depth and completely the chapter of surveying. All the three parts I have covered, and these like the uses of it is very important as per your exam point of view, and you should know this uses of surveyor. So thank you so much.